Actually, the ureters, just like the kidney, will be retroperitoneal. I know us understand what we mean by retroperitoneal. And then, of course, goes to the bladder where the urine is stored until a certain amount where now the urge to micturate or pass urine takes place, and then you appropriately in appropriate environment and so on, then you pass out urine through the urethra. So basically that is the system, that's the anatomy. Also in the second diagram, also we are seeing the same, the anatomy, just emphasizing that you have got to really understand the anatomy very well with physiology so that you're able to understand the disorders that we talk about. So you have to be able to understand the anatomy and the physiology well. So you can see the kidneys there, the ureters. Basically, ureters are like just conducting, it conducts urine, it doesn't absorb urine or anything. Likewise with the bladder, there's usually no absorption. You remember the epithelium of the urinary system, most of the ureters, the bladder is transitional epithelium, a transitional type of epithelium, usually in the bladder. And then there is the urethra. And then just another diagram looking at the kidneys and its relations. So you can see the kidneys, both kidneys, there is what we call suprarenal gland. Yeah, adrenal glands. So you can see the right adrenal gland just above the kidneys, and that's why they are called also suprarenal, just above the kidney. So we have the left adrenal gland and the right adrenal gland. They produce hormones. Adrenaline, among other hormones that these glands produce. And then you can see, of course, both the left and right kidney, sometimes they have slightly different relations. For example, you can see at the right kidney, hepatic flexure, that is where the ascending colon turns to become the transverse colon. That is where it will come in contact with the left kidney. With the right kidney, you have the right hepatic flexure. And then also the small intestine, part of it will come in contact with the kidneys, but although they are not attached to each other, and you can see where the duodenum will touch, that is the second part of the duodenum where it will come in relations to the right kidney, so it will be anterior to it. And then you see the left kidney, you have it will be related to the jejunum, part of the jejunum. It will be related to the splenic flexure. That is where the transverse colon turns to become the descending colon. It's called the splenic flexure. And then, of course, you can see it's related to the spleen anteriorly, and that is the left kidney. Then you have the relations with the pancreas. So the pancreas will be more of anterior to it. Then the stomach, the superior part, medially, is where the stomach would be. Those are relations. You can see the ureters. Of course, you can see, as I say, there is the blood supply. It has to have blood supply. There is the renal artery and vein, the left and the right renal arteries and vein. The renal artery is a branch of the aorta, whereas the renal vein drains the kidney and goes into the vena cava. Yeah, so, and then of course you have to be able to understand a bit of histology. In fact, many of the things that you look at, you need to understand the microscopic anatomy of the kidney. Yeah, of course, some of these, if you are to cut the kidney, some of them you probably can see them grossly. So you see the kidney has what you call the capsule, basically the covering, whatever covers the kidney is what is called the capsule. Then under the capsule, we have the cortex. Yeah, then from the cortex, we have the renal medulla, the pyramids there. And then from the pyramids, you have the minor calyces. And then we have the major calyces that joins to form the renal pelvis. And then from the renal pelvis now, the urine flows through the ureter and goes to the urinary bladder. And then, of course, looking at the upper part, more microscopically, you'll be able to see what we call the glomerular capsule. Glomerular basically is a collection of blood vessels, capillaries, and so on, that forms part of filtration. That is where the filtration to form urine takes place. in the glomerula. Yeah, and I think we'll be able to look at it. And you can see the collecting duct. That is after the urine has been formed, it goes through those. So they're also called nephrons. Yeah, so basically nephrons consist of glomerular capsule, those tuft of blood vessels. Yeah, and then of course, from the collecting duct, it goes now to the minor calyces or major calyces to enter into the renal pelvis. That is a nephron. Nephron is the functional unit of a kidney. So the kidney has very many millions of nephrons. Yeah. So usually by the time somebody has renal failure, will have lost maybe over 80% or 90% of the nephron. So this is the functional unit of the kidney. Basically, this is where urine is made. For example, you can see in that diagram, you can see the a branch of renal artery. It comes in what we will call afferent. Afferent now is coming towards that glomerular capsule. So we have the afferent arteriole coming in, forming the glomerulus. Yeah, and then that is where now the filtration takes place. And then after the filtration has taken place, there is the efferent arteriole that takes away the blood. Yeah, so in that capsule is where filtration takes place into that space, that capsule, glomerular capsule, and in that space there, the filter, the urine now will get in there. And then we will go through, there is the proximal convoluted tubule. Yeah, so the tubules mostly there will be reabsorption of some whatever was filtered in the glomerulus. Some of it will be reabsorbed, some of it will be secreted into that space. And so it will go through, you can see medullary loop. That basically is the tubule, we call it loop of Henle. And you can see there is a narrow part and then there is the wider part. The ascending part is wider, the descending part of the loop of Henle. The descending part is narrower than the ascending part. And then eventually you go to the distal part, what we call distal convoluted tubule. So convolution, basically, you see the way it is not straight. So it's curved in a way. That's what they basically mean by convolution. And this one basically helps it create a greater surface area for reabsorption and even secretion of some substances. So eventually, by the time you get to the collecting duct, there will be minimal secretion into the duct, and there will be minimal absorption. And that is when the one now that from the collecting duct, it goes to the calyces, the minor calyces and major calyces into the pelvis. Basically, by that time, the urine has been fully formed. So basically, you can see those arrows basically are showing the direction. There is one that is showing the direction of blood flow coming in through the afferent arteriole and getting out of the glomerulus through the efferent arteriole. And then you can see the direction of urine being formed at the glomerulus and flows through the proximal convoluted tubule, through the loop of Henle, into the distal convoluted tubule to join the collecting duct. And you can see many branches, basically those are distal convoluted tubules that are joining the collecting duct. So basically that is the nephron, that is the functional unit of a kidney. And then of course you can see as the vessels from the efferent arteriole, it branches out to form peritubular capillaries. So peritubular is around the tubules. You can see those capillaries around the tubules, finally to become into the venules and goes back to the branch of renal vein and goes all the way to the renal vein and the inferior vena cava. So this is the functional unit. So the kidney has so many of these. Of course, they are microscopic. You'll have to look under the microscope to be able to see them. They are in their millions. And basically, this is where urine is formed. In a more closer look, that is, we're looking at the glomerulus and looking at the glomerular capsule. So you see there's the afferent arteriole, then there's the efferent arteriole, then glomerulus. Basically, those are tuft of blood vessels that help with the filtration. So here, as you can see, the pressure from the incoming blood will be higher than the pressure that is getting, and then you can see the efferent arteriole will tend to be narrower. So this helps increase the pressure within the glomerulus for the purposes of filtration. Yeah, and then you can see the glomerular capsule, and when there is that space where now urine that is being filtered will come into that space, and then eventually into the proximal convoluted tubule, where absorption will be, some things will be reabsorbed. So many things will be filtered, but some will be reabsorbed back into the blood, and others will be secreted from the tubules into the urine. So by the time it reaches the renal pelvis, urine is fully formed. That is just another diagram showing some histological details, histologically, so to speak. So you can see the proximal tubule, it has some hair-like, almost V-like. So it helps basically in absorption. As we have seen even in the small intestine, it increases the surface area. You can see the proximal tubule, those hair-like projections, increases the surface area for the purposes of absorption. Because many things will be filtered out from the blood, but some of it will require to be reabsorbed. And of course, there will be some secretion from the tubules as well. Yeah, and then you can see the mesangial cells, you can see the distal convoluted tubules, you can see the juxtaglomerular cells. Yeah, so when you talk of juxtaglomerular, it's around the glomerulus, juxtaglomerular cells around the glomerulus. You can see the afferent vessel, that is the one that is coming in, and then you can see the efferent vessel. And around there, between the efferent vessel and the afferent, we have the mesangial cells. Yeah, and then you can see the glomerular capillaries. So within the glomerula, we have the capillaries. And that is where the filtration takes place into the urinary space, and then into the proximal convoluted tubule. Just another diagram showing the filtration in the glomerulus. Filtration in the glomerulus. You can see the afferent vessel coming in, the wider vessel, and then you can see the filtration. Yeah, basically we have the capsule. So whatever is filtered gets into that space and into the proximal convoluted tubule. And you can see the pressures will be different. For example, in that glomerulus, the pressure will be, the net filtration pressure will finally be like 1.3 kPa. You can see the glomerular hydrostatic pressure coming in, you have like 7.3. And then we have the blood osmotic pressure around 4. So that is why when you calculate the final net pressure, net filtration pressure that will be filtering out will be around 1.3. Because there is the capsular hydrostatic pressure, that is the one that tends to bring in things back. So if you add 7.3 plus 4, that is like 11. Blood osmotic pressure, then you subtract, you finally will get around 1.3. That is the one that will be forcing things to come out of the blood into the glomerular space and into the proximal convoluted tubule. And I'm sure you will be able to, and probably you've looked at this and in details in physiology. That is just a scanning electron microscope of glomerular capillary tufts. So they will look like that. You can see the tuft scanning electron microscope. Yeah, so that is how they will look like. Those are the glomerular, glomerular capillary tufts. Then an electron micrograph also showing glomerular capillary. So then you can see there is a lot of pores that allows things to come out into the capillary, into that glomerular space for filtration, the ultrafiltration. So it's able to allow some filtrate. And that's how basically the kidney is able to remove waste material from the blood and makes urine, and so that we are able to excrete. So that if you have renal failure, then that will not be effective, and there will be a lot of accumulation of urea and even electrolytes, potassium, sodium, and so on within the blood, and that will probably cause problems. So blood vessels within the kidney, as I've already said, you have a renal artery that is a branch of the aorta. And of course, as it gets into the kidney, it branches severally and goes into the glomerular. You can see the afferent arteriole in the glomerulus where the filtration takes place, and then there is the efferent vessels. And then there are the capillary networks supplying the nephron, the peritubular capillaries around a tubule. Because you remember around in those tubules, there'll be secretion of some things also, and then there'll be reabsorption. Those things that are reabsorbed within those tubules, they are reabsorbed back into that capillary network, and it goes back to the renal vein eventually and to the aorta. So it's good to understand those things. Just another diagram showing the formation of urine, which you've already mentioned how urine will be forming. You see in that part is the basically from the blood into the nephrons. So some filtrate is coming from the blood into the nephrons. Then in the second part, that is in the tubules, we have reabsorption. That is basically from the filter that has been filtered and the glomerular capsule being reabsorbed. Part of it will be reabsorbed and it gets into the blood. And there will still be something that will be secreted from the blood into the filtrate. Yeah, so that is why you see the third one is secretion from the blood into the filtrate. Yeah, and then of course, so eventually it gets into the collecting duct. Yeah, and as urine. Yeah, so by the time it reaches the collecting duct, that means now the urine has been fully formed. And this one eventually is able to balance so that the body has just the right amount of potassium, right amount of sodium, another electrolyte. Right, still in the blood, there will still be some urea, but a minimal amount. Likewise, there will be some creatinine. That is why that filtration comes there, it has to be reabsorbed. Some will be reabsorbed, some will be secreted, so that we finally have just the right balance of this filtrate within our blood, and most of it will be filtered as urine. Just again, the anatomy of the bladder, you can see the ureters. Then you can see the opening of the ureters, that is into the, looking at the inside part of the bladder. You can see that place called the trigone. It's usually a more smooth area. You remember the rest of the inner surface of the bladder will tend to be not smooth. But that particular area called the trigone, that is the area, almost a triangular area between the two ureters, opening of the ureters into the bladder, and the urethral orifice at the neck of the bladder. So we have what we call the trigone. It's usually much smoother if you are to look at it grossly. And then, of course, we know from there the urine will be stored in the bladder for a specific time until a certain amount. In most people, maybe around 400 ml, even sometimes to 500 ml. Then you have the urge to micturate, and then the sphincters will open and the urine will come out through the urethra. Just again, another anatomy, just showing how the ureter gets into the bladder. It doesn't go in a straight horizontal way. You see, it goes in an oblique way. And that helps also acting as a valve to prevent urine from refluxing back, that is getting out of the bladder into the ureter. Usually urine should not go back into the ureter. If it goes back, it's likely to cause problem. So the way it enters the bladder in an oblique way helps as a valve to prevent reflux of urine from the bladder into the ureter. Of course, you can see the inner layer lined with transitional epithelium, the outer layer of bladder fiber, which is mainly fibrous tissue. Then we have the smooth muscle of the bladder wall, the trusor muscle, and I think we talked about it last time.